Hi everyone, my name is Dr. Yuz Yusof from Leeds, UK. I'm reporting for Room Now for this EULAR Congress 2021. Today, I'm delighted to be joined by Dr. Lucy Carter from Leeds, UK. Hi, Lucy.
Hi, yes.
Yes, so Dr. Carter presented an oral presentation today in the SLE abstract session. The abstract number is OP0134. Okay, so Lucy, can you please tell us the background of the studies and the objectives?
Sure. So, like a lot of centres, we're familiar with using rituximab for our more resistant SLE patients. But we've previously observed that, in fact, some cutaneous disease fares less well than other organ systems following rituximab treatment in lupus. And in fact, there's a small group of patients in our centre in whom we've observed actually de novo skin flares or completely new skin lesions after they've been treated with rituximab, which appears quite paradoxical. So we wanted to investigate that a little bit further. And what we did was use a registry cohort that is a UK-wide multi-centre registry, BioLag Biologics Registry, and characterise skin responses in those patients after they'd undergone their first cycle of rituximab treatment. And those patients provided us with whole blood for TACMAN PCR evaluating gene expression scores related to type 1 interferon signature. So we used interferon score B, which is something we've previously described in our group and validated, and it's a measure of interferon pathway activation. We were really interested to find out whether or not we could detect any baseline immunological phenotype for those patients who went on to develop more resistant skin disease.
Okay, thank you so much. So it is a prospective in the study from a UK registry, so it's a very strong one. So can you just summarize to us the key findings from your results?
Sure. So in the registry, we observed, similar to how we had observed in our centre, that the majority of patients with mucocutaneous BioLag disease who were treated with rituximab actually did very well. So more than 75% of them obtained an improvement in their BioLag scores in the mucocutaneous domain of one or more grades. But there was 15% who had either resistant or new BioLag A or B disease in the skin. And that was unlike any of the other organ systems that were, as we assessed them. It turned out to be the most resistant organ domain in this cohort. And in fact, it was mucocutaneous disease was the main reason for overall treatment failure in these patients. So when we characterized how their interferon score behaved according to response, we saw that a higher overall whole blood interferon score was associated with an overall therapeutic response, and that was a positively prognostic marker. It didn't have any association with their baseline skin disease, but a lower score B a lower interferon score B at baseline picked out that small group of patients who had resistant refractory skin disease after rituximab treatment. We thought that was an interesting finding that might be pointing towards an endotype of disease that was more resistant.
That's really an interesting finding. The resistant cases have lower interferon scores. Yeah. So in terms of how are you going to try to put this into practice? Anything that this finding can inform our practice?
Yeah, I think it's a long way off being a directly translational finding. I think what I would say is that it shouldn't overall dissuade us from using rituximab in our patients with mucocutaneous disease, because majority of patients we observed did do well. But I think it's important to be mindful that this can happen, and that we do see more resistance in the skin than we do in perhaps other organ systems. And I think we should be, working towards understanding that really refractory interferon low group of patients a little bit more.
Very good. And lastly, so what's your plan for future work following this study results?
Yeah, so we're fortunate. While we've used TaqMan PCR on whole blood to measure the interferon status of these patients, we've actually got a wider profile of gene expression that we can look at. So we've also got gene expression data coming through relating to other modules such as plasmablast or inflammatory or myeloid lineage. So those are, we'll be able to add to the picture for these patients, really. So I'm looking forward to being able to analyze that.
Yeah, we're looking forward, to hear from you, soon as well. So I would like to thank you for your time, for spending time to be interviewed today. We all learn and interested in your abstract that you presented. So thank you everyone for listening. So tune into Room Now for more video and news updates. And you can also follow me at my Twitter handle Yuz Yusof. Okay, thank you. Bye-bye.
Bye.